Hi, Dr. Akki. Hi, Dr. Akki. How are you feeling?
Hi, Akanksha. I'm a little better, but still you can hear the nasal voice. But yeah, I'm better than yesterday. Thank you.
I can't hear you somehow.
Oh, really?
I don't know. Lakshmi, are you able to hear him? Am I the only one not able to hear him?
I'm able to hear them.
Did you say you can hear me?
Yes, I can hear you.
Okay.
I don't know. I'm not able to hear anyone. Mm. Hi, Dr. Akki. Can you hear me now?
Yeah, I can hear you.
Oh, cool. I can hear you too. Great. Awesome.
Yeah.
How are you feeling today?
I'm still not completely better, but better than yesterday. Thank you, though.
Yeah, my kid is also sick, and I think I'm also starting to feel sick now.
I think it's going around, I think.
Yeah.
Yeah.
Let me message in the group that we have started so that people will start.
Okay.
Okay, you can get started. Meanwhile, people will keep on joining.
Okay, cool. So I thought we would start with PBC today, unless people have questions from things that we discussed yesterday. So this was one of the cases that I found on Path Presenter for PBC. And as you can see from LOPAR, once again.
It started? Was started? I'm seeing this. It started?
Yes.
No.
Do you want me to continue?
No, I muted. I think she was not talking to you. I think.
Oh, okay. Okay.
Yeah.
Oh, yeah. So as you can see on LOPAR, the portal areas look pretty blue. And within the lobules, there's not much happening. And they look, eosinophilic, but nothing major happening within the hepatocytes. So on LOPAR, it doesn't look much different from the chronic hepatitis pattern of injury. So you were asking me yesterday, what are other differentials? So this somewhat looks on LOPAR like a chronic hepatitis pattern of injury. But then when you go in, zoom in, and start looking at what's happening in the portal areas, yes, there is a lot of lymphoplasmacytic infiltrate, mainly lymphocytic, but you can see that the lymphocytes are in the bile duct epithelium, and the epithelium itself doesn't look very healthy. Normal bile ducts, as I discussed yesterday, should have evenly spaced nuclei with a very punched out lumen. Almost looks like a well-arranged pearl necklace, but you can see here, this bile duct is somewhat irregular. Even this one, you can see the lumina or lumen are not very punched out. They're in different shapes and forms, and the nuclei are not evenly spaced. They are like unevenly spaced. Some of them are falling on top of each other. So that shows that there is bile duct injury happening. And let's look at a couple more portal areas to get a better idea. So these bile ducts are not too bad. As you can see, they're somewhat evenly spaced nuclei. Let's see. And in this portal area, it's even hard to find out where a bile duct is, even though it's a decent sized portal area. Let's look at these other cores. Yeah, this is a good one. So you can see that there is a decent amount of portal inflammation. There is the hepatic artery, portal vein here, and then the bile duct. And see how bad the bile duct looks. I think that's the highest, unfortunately, I can go. It's not letting me go beyond that, but you can appreciate that the nuclei, instead of being evenly spaced, see how much space there is between the nuclei here? That's one feature, irregular nuclear spacing. These are features of bile duct injury, And then you can see that there is cytoplasmic vacuolation here. See the clearing out of the cytoplasm in some of these pockets. That's another feature of bile duct injury. And then you can see the lymphocytes within the bile duct epithelium. So those are three features of bile duct injury already in this one single bile duct. So
sorry, is this a transplant?
no, this is a PBC.
Okay.
I'm sorry, Dr. Akki, could you please repeat those three features again? I'm sorry.
Sure. So normal bile ducts should have evenly spaced nuclei. I'm trying to see if I think this previous core had it. Like at least some of the bile ducts were normal. Let's see here. So forgetting that this is a PBC liver, if you just look at the bile ducts, these bile ducts look, at least in this one particular portal area, these two bile ducts look somewhat healthy. And so see how evenly the nuclei are spaced here around the lumen, and the lumen itself is very punched out, either round or oval shaped. And that's how you would expect normal healthy bile ducts to be. But in this core, in this one particular field, you can see that the nuclei are not evenly spaced, right? They're irregular placement of nuclei. That's one feature. And then, you can see here some cytoplasmic vacuolation, these white spaces. It's not artifact. These white spaces in the cytoplasm of these bile duct epithelium cells, those are vacuolations. And so that's abnormal. That indicates injury to the bile duct. And then you can see intraepithelial lymphocytes. So those are the three features that you commonly see with any kind of bile duct injury, not just specific for PBC, but you can see in other disease processes too. But when this becomes exacerbated, the number of lymphocytes that are invading the bile duct nuclei becomes increased. And that's when we refer to it as the florid duct lesion. And see here, you can hardly make out a bile duct. You have the portal vein, you have the hepatic artery, but it's hard to make out the bile duct. So that means that in that one portal area, even here, see it's hard to say whether this is bile duct or not. It may be even here. So you have the portal vein, and you have the hepatic artery, but where is the bile duct? It's hard to say. It most likely is that the bile duct is injured so severely that it's almost obliterated. Here you have an intact bile duct, but it's still, the nuclei are not pretty regular. There is irregular nuclear spacing here. So clinically, when do hepatologists start suspecting this? It's, as you guys know, classically you will see this more commonly in females. About 80% of the patients are females, usually between the age group of 40 to 60, and these patients present with fatigue, weight loss, pruritus, jaundice, hepatomegaly, etc. And then when they do the liver enzymes, they notice that more than transaminases, it's the alkaline phosphatase that's elevated. And that goes with the fact that, alkaline phosphatase is a surrogate marker for bile duct injury, right? So more than 1.5 times elevation of alkaline phosphatase. And then once they suspect that this is not a viral injury, because they would have already done viral markers, then they start doing autoimmune markers like ANA, ASMA, and AMA. And if this is truly a PBC patient, anti-mitochondrial antibody would be elevated, especially the titers will be high, greater than 1:80, something like 1:160 or even more. And then another serum marker that is helpful is serum IgM that is elevated in these conditions. So overall, the clinical presentation of a female with fatigue, jaundice, pruritus, and then serologically, there is ALK phos elevation, but transaminases are not too high. And then there is AMA, IgM elevation, and then they do the liver biopsy, and we get it, and we see this pattern of injury where majority of the portal areas have this lymphoplasmacytic infiltrate, predominantly lymphocytic. There are very few plasma cells here. And then, the infiltrate is actually invading the bile ducts, all put together. Sometimes it's not always easy to find granulomas in the biopsy. If you find it, it kind of supports your diagnosis even further. But not seeing a granuloma should not dissuade you from calling it PBC. When you see the florid duct lesion and it fits with the clinical picture, you can say that this is PBC. I'm trying to think if I've missed anything else mentioning. So, and then we also, do the trichrome at the same time. Let's see if they have any here. I think the first page had some. I think this is an explant, and you can see, although it's not a trichrome, let's see. I thought they had 1 or 2 trichromes, but looks like they don't. Yeah. So although this is not a trichrome, but this is an explant, and you can see that there's already advanced, fibrosis. There's some periportal to like delicate bridging here. See these extensions? It's going from, one portal area to another. And the bile ducts are almost obliterated in a lot of these portal areas. So, and the classic cirrhosis pattern is biliary cirrhosis in cases, which is more like a jigsaw pattern of cirrhosis. I think there was one somewhere here with the trichrome. Yeah, something where, the cirrhotic nodules, instead of being, just round, they are more like jigsaw puzzles. They fit into each other. You'll have to see to appreciate it. This is not the best, but instead of being just like these round nodules, they are in like different puzzle formed shapes, but they fit into each other. So that's the kind of cirrhosis you would see normally. Any other questions on PBC?
Is that a jigsaw puzzle kind of nodule seen in any other conditions than PBC?
Yeah, you can see it in PSC as well. Any
Okay.
form of cirrhosis. So PBC and PSC both can produce that kind of pattern.
Okay. So,
And NASH
but only.
cirrhosis has the same too? Sorry, I interrupted.
Sorry, go ahead, please.
What did you say, sir?
I said, can cirrhosis secondary to NASH has jigsaw puzzle pattern too?
Usually not, at least not described in textbooks, but sometimes you may see, but not the classic ones.
Okay, thank you.
Usually for NASH, they either micro or macrovesicular steatosis. Sorry, micronodular cirrhosis. Okay, so that's PBC, and then moving on to, let's see, oh yeah, there was PSC. Yeah, this is a explant of a case of PSC. So for PSC, we need, it's not a primarily path diagnosis. That's something that every pathologist should be aware of. We can only make a suggestion. So usually we don't, top line it as PSC unless there is a strong imaging finding that correlates with it. So you have to have the patient investigated on imaging that shows that there is this stricture of bile ducts leading to beating of biliary tree. That is the classic clinical picture that we would like to see before we call it PSC on biopsy. So once again, the patients present with elevated alk phos because bile ducts are affected. And then here, it's more common in males than in females. And as you guys know, patients with IBD have a higher incidence of developing PSC. And then patients with IBD are followed up for this, especially if they are males. And then outside of IBD, when a male presents with similar like jaundice, pruritus, fatigue, right upper quadrant pain, then the hepatologist goes ahead and investigates it. Once again, they do viral markers, autoimmune markers, and look at the liver enzyme levels. And so they notice that the viral markers are negative. The liver enzymes, especially alk phos and GGT, may be elevated. And then when they do serology, especially the autoimmune markers, ANA may be elevated, but in most patients, P ANCA is positive usually. And that's one thing that's helpful. And anti-mitochondrial antibody is negative. And then, they go ahead and do the biopsy. And if it's truly classic PSC, then you will see that the bile ducts have this onion skin fibrosis. So let's see what we have here. This is not pretty classic. Let's see if we have an actual biopsy. Oh, this is somewhat like a jigsaw puzzle of biliary cirrhosis. See how they kind of try to fit into each other? Not classic still, but close. Let's see. Okay.
So you don't always see onion skinning in PSC, no?
You may not see the real severe form of onion skinning, but you will see some kind of, you usually appreciate some kind of periductal sclerosis or fibrosis. It's usually mild. This is not, once again, the best. I mean, there is a little bit, a hint here, but I'm not appreciating a good bile duct here, unfortunately, to show you guys it's periductal.
So how is this type of fibrosis different from the micro or macronodular cirrhosis?
Say that again.
No, how is this type of fibrosis different from micro or macronodular cirrhosis, like you see in alcoholic liver disease?
You're talking about when it's finally going into cirrhosis, but we are just talking about when it just starts initially.
Okay.
In this case, Dr. We go back to that case. No, the middle one, this one. Yes, there was a core down there that had some good onion skinning down. down. This over here, can you, like, this is the best, I think. A
Yeah,
little bit maybe.
not the best, but yeah, there is a little bit of fibrosis or sclerosis around the bile ducts. And one thing that kind of helps us is, normal bile ducts should be, very pearl necklace like this, right? And see how irregular this bile duct is, and even here. And so there is a little bit, this is how majority of the cases will be, because on a biopsy, especially, you're getting the innermost parenchyma of the liver. And so the smaller bile ducts may not show a lot of sclerosis, but on imaging, what they pick up are these peripheral larger bile ducts. And so they are usually strictured. And so the extent of histologic changes is much more pronounced in the larger, around the larger bile ducts than in the smaller bile ducts. So which is why we struggle sometimes on a biopsy to appreciate the sclerosis. Let's see if there are other biopsies. No. Yeah, unfortunately, I think, let's see, how about this one? Oh, that's the end stage of it. Yeah, I guess for us, in this case,
You can also show us a Google image. I mean, that works too. Like
That's
just
so let's see. Let's open this and see if it works. If not, then we can go to Google. Oh, this is already erotic.
but I can appreciate the jigsaw that you were talking about in here
Yeah.
very nicely.
Yeah. Let's see. Yeah. The stuff like this. See how the bile duct, instead of being very uniform, I think it's taking me to path outlines. Instead of being very uniform, see how irregular the bile duct is? And then you see this somewhat edematous. Again, once you look at a few of them, it kind of brings your attention to it. Because here it doesn't look like classic, but because it almost looks very edematous. So that's also another feature that should draw your attention to the portal area or the sclerosis aspect of it. Because it's not very thick fibrosis in this image, but the fact that there is edema, and then you see this irregular bile duct, and then you see this whirling effect of the tissue around the bile duct, is a hint that there is mild, sclerosis already starting there. And then here, in this case, you have the portal vein here, hepatic artery, and there's no bile duct, and the bile duct, entire bile duct is sclerosed here. So in some biopsies, you will see this. You just shouldn't think that, oh, this is a portal area that doesn't have a bile duct. Instead, when you have something like this, then it's an indication that it's a sclerosed bile duct, which is obliterated totally. So stuff like that. It's a spectrum of changes, something that is as mild as very mild periductal sclerosis to something very severe, And there's one more picture here. See how there is a little bit of fibrosis around the bile ducts. And there is this one here. So several ways, even here, it's somewhat subtle because this bile duct is very normal looking. So once you see a couple of these over time, you'll start picking up. See the sclerosis here. It's mixed with edema, and that's what makes it a little challenging for you to appreciate the thick sclerosis, but it's there.
Dr. Akki, what are the early changes that you see in this condition?
The first thing that you would see is this kind of very mild sclerosis around the bile ducts, because usually the inflammatory cells are not too many a lot of times.
Yeah, that's
So,
correct.
You will start appreciating, very mild periductal sclerosis. That's why once you've ruled out, on low power, let's go back to this case. On low power, when you look at a liver biopsy, if you notice that there is nothing happening either in the lobules or there's not many inflammatory cells in the portal areas, then you start paying attention to all the structures within the portal areas. And so you should always make it a point to look at, okay, how does the portal vein look? Is it normal? How does the hepatic artery look? Is it normal? And then how does the bile duct look? Is it normal? And then when you look at this bile duct, it's like, oh, it doesn't have a normal contour. It's like somewhat haphazardly arranged. What's going on? Tissue around it, and it's somewhat zero. So a lot of times the clinicians would not have, again, I'm talking about private consults that we get, they wouldn't have done the complete workup. So we can't confidently call it PSC. So we end up giving a hint that it might be. So we suggest that they actually do additional workup for this patient, both in terms of imaging to look at the biliary tree and in terms of doing serology, look for Pianka, etc. And so, if everything else is okay, and we say that there is foci of mild periductal sclerosis, and then say seek comment and say raise the possibility that this could be early PSC, so yeah. Anything else? And again, eventually it'll go through fibrosis, different stages before it reaches the stage of cirrhosis. And see, this is kind of midway before it forms like complete jigsaw puzzle. I think this is like stage 3, where you're seeing fibrous bands connecting different portal areas. It's hard to appreciate here what's central versus what's portal, because a lot of portal areas have lost bile ducts, and then there's some bile ductular reaction. So once it reaches this stage, it makes it challenging to clearly say what's what. But you're not seeing too many of these discrete cirrhotic nodules. So it's kind of incomplete cirrhosis still, but it's on its way.
Okay.
So those are PSC and PBC. And then I was thinking we could go to transplant liver.
Sure.
So let's see. Rejection. If not, we'll just search for liver. I think Michigan had liver transplants, quite a few. So,
How many of you all, meanwhile, get transplant cases of liver in your practice?
Well, I've seen during residency, during training a lot. But well, I'm starting my work next week, so I will know. But I doubt if they receive transplant over here.
so
Lakshmi, Shweta, what is your experience?
Only in residency. I don't practice it here.
Okay, yeah.
I used to have in my fellowship, but nothing in current practice. Yeah.
Yeah, they usually send it to the experts, the transplants, I think. I mean, I have seen the liver biopsies over here, but the transplants, they don't send it.
yeah. So I have one here. Let's see how good this is. So for anyone who is starting out, I would highly recommend the UPMC website for grading rejection. This is the one. So I usually say, UPMC TIPS or UPMC liver RAI, which is rejection activity index. So, the most commonly encountered rejection in the liver is acute cellular rejection, right? And then the other rejection that you'll encounter is chronic rejection. And then less commonly is antibody-mediated rejection. So very common is acute cellular. So when you're grading it, no matter how long you've been practicing it, if there is a period where you go without looking at it, it always helps to like bring up this table and compare what's in this table versus what's on your liver that you've gotten. And so, as you know, clinicians, when they do these biopsies to assess for rejection, they're already um, highly suspicious that something is wrong. And they usually know, they know their patients very well, who take their immunosuppressive medication seriously and don't skip it, and who has a tendency to skip it and not maintain their immunosuppression well. So the way these patients present usually is, one or two ways. Uh, Immediately following transplant, they have a protocol. Some institutions do protocol post-transplant biopsies. 1 week after transplant, and then 2 weeks, and then 4 weeks, and then 8 weeks, etc. And then once they cross that 8 to 12 week period, then they do it like once in 6 months or so, and then eventually once a year. Others may do it different ways, but protocol biopsies usually they're usually not suspecting rejection because they're trying to see how the organ is doing with the amount of immunosuppression they're giving the patient. Because usually, at least the first couple of days they're still in the hospital, and then they send them home, and they want to adjust the immunosuppression. They start them with either tacrolimus, which is Cellcept, and then mycophenolate maybe, and then they want to assess whether the dosing is appropriate or not. They try to limit it to one medication rather than 2 or 3, because they know it's patients are better with one than more than one. And so when they do these protocol biopsies, they want to taper the dosing of those immunosuppressive medications depending on the patient's body status, how they're responding to it. If we tell them that there's zero inflammatory infiltrate in the transplant biopsy, then they will more likely, they look at the enzymes and then they see that since there's no inflammation in the portal areas whatsoever, they might actually lower the dose, because what's the long-term consequence of over immunosuppression?
Polyoma.
That can happen more commonly in kidney, but in the liver, there is a fear of PTLD. So that's why they tend not to. They tend to err on the side of under immunosuppression than over immunosuppression, because they don't want that to happen. Because it's so hard to get a donor organ. Now that they've gotten it, if you try to over immunosuppress them when they develop PTLD, then that's a worse problem for them. So they try to balance the dose better. So now, thinking on the side that they've somewhat under immunosuppressed, then we'll see inflammatory infiltrate. And in a scenario where there is rejection happening, we already know from the clinicians and from the chart, because we never look at these biopsies just blindly. We want to know how the liver enzymes look. And usually transaminases are elevated when there is ongoing rejection. And if there is bile duct injury, alk phos is also elevated. And then we get the liver biopsy and we look at it. And as you can see, there's already inflammatory infiltrate in the portal area, right? So this is a portal area. We have a bile duct here. It's somewhat blurry, I don't know. And there's another profile of bile duct here. And then portal vein here. and then hepatic artery. And then, as you can see, the inflammatory infiltrate, it somehow looks a little bit mixed, because you can see some eosinophils too here. And the lymphocytes look a little activated. And then when you look at the bile duct epithelium itself, it doesn't look healthy. See how irregular the nuclei are spaced? You know, these two nuclei are like almost on top of each other instead of being evenly spaced. And there is a wide gap between the nuclei here. And then there are some lymphocytes that are already entering the bile duct epithelium. So that tells you already that there is bile duct injury. And then you look at the portal vein endothelium, and you can see that the inflammatory cells are somehow trying to undermine the endothelium of this portal vein. They're still not like completely lifting it up, but they're kind of immediately beneath the endothelium. And then same here in this bile duct too, it doesn't look completely healthy. It looks somewhat more eosinophilic, kind of stands out. So we don't assess rejection with just one portal area. You have to look at the whole. And technically, we need at least 10 to 12 portal areas to give them a better indication of the RAI. And when we have less than that, then we do tell them that, hey, look, what we tell you may not be representative because we don't have enough portal areas. But assuming that we have enough portal areas, this is another portal area where you're seeing bile duct injury, right? See how irregular the bile duct nuclei are? There is subendothelial inflammatory infiltrate here. Again, it's still not lifting the endothelium that much. So there are two bile ducts which have portal inflammation, bile duct injury, subendothelial inflammatory infiltrates, etc. And so we go through these different portal areas and see here, unfortunately, this portal area is kind of lost during cutting, I think. So the rest of the biopsy doesn't look too good for assessment, but imagining that these two portal areas that we looked are pretty representative of what's happening, and if we have 10 of those portal areas with similar changes, then we can go back to this table and then look at it and say, you know, what's happening in this liver biopsy? And I feel like, you know, there's expansion of most of the portal areas by mixed infiltrate containing lymphocytes and occasional eosinophils, etc. So I would give a score of 2 for portal inflammation. And then we look at the bile duct damage. And I think that most or all of the bile ducts are infiltrated by inflammatory cells here. And I still don't see degenerative changes in too many bile ducts. So I would give a score of 2 again for bile duct injury. And then venous endothelial inflammation, there's only subendothelial lymphocytic infiltration involving some, but not a majority of the portal or hepatic venules. So I'd kind of give a score of 1. Again, I'm doing this based on my experience, so it takes time for people who haven't done this to actually appreciate what I'm trying to say. It might look like voodoo, but so a score of 2 for portal inflammation, 2 for bile duct damage, and 1 for venous endothelial inflammation gives it 2, 2, and 1 is 5. So total score is 5 out of 9, and that's mild acute cellular rejection. And so you can actually know, if you go to this paper from 1997, I think it shows you it tells you, I think in page 2 of this paper, you can see that, you know, 4 to 5 is mild, 6 to 7 is moderate, and 8 to 9 is severe acute rejection. And anything less than 4, so 2 and 3 is kind of borderline. We don't say borderline, we just say indeterminate if it's less than 4. So that's how I would call this. This is mild acute cellular rejection. Again, you have to have the clinical context. You know, it has to be post-transplant. The liver enzymes should be elevated, especially transaminases and alkaline phosphatase. And then you see this picture of inflammatory infiltrate in most of the portal areas with bile duct injury, subendothelial inflammation, and and then portal inflammation in a majority of them. Yeah, so that's how I would do it. Let's see if there are others where we can kind of see a different version. Any questions so far? Was it all over the head transmission?
Just ignore.
Sorry, I
Priya,
couldn't.
you're not very well visible. Like you're not audible very well.
32235.
Say that
What?
again. 322.
35 case number.
Oh, on here.
Mm-hmm.
32235. Can I type that? 32235.
You have to filter it.
No, the image ID. Check by the image ID. Put that in the other column.
Here, right? Okay, 32235. And then filter.
Mm-hmm.
Okay. Oh, that's what we saw just now.
Oh, okay.
Yeah.
Okay.
Let's.
You
see.
can just say rejection and in the filter if it comes.
Yeah, let's see. There's ductopenic, but that's more common with chronic.
There's a mild one in the bottom.
Which we kind of, yeah. So I was hoping to see a severe one. So, but again, so low power once again, just like chronic hepatitis pattern of injury, there's usually not much happening in the portal areas. And you see blue, sorry, not much happening in the lobules, but you see blue portal areas. And then you go closer and you see that the portal inflammation is pretty mixed with lymphocytes, eosinophils. Sometimes you can see a few plasma cells. And then, bile duct here is injured. The way I can tell is that there's an intracytoplasmic vacuole here. I don't know if you appreciate this white space.
Mm-hmm.
And in the epithelium, there are lymphocytes. These are lymphocytes in the bile duct epithelium. So there's definitely bile duct injury. And then see here, there's endotheliitis. The bile duct, the portal vein endothelium is lifted up. It's kind of, you see this hobnailing of the endothelial cells. So that's early endotheliitis. And then let's see.
Endotheliitis also comes in the scoring?
Yes, in fact, endotheliitis actually gives you more confidence to call it rejection because, bile duct injury is somewhat non-specific, but endotheliitis is more important. So if we go back to the BAMF scoring system, you see here venous endothelial inflammation. In fact, when there is frank endotheliitis in more than 50% of the portal areas, we give it a score of 3 actually. So where were we? Yeah. Once again, this is another, or probably the same bile duct. Okay, let's see here. So once again, there's a little bit of subendothelial inflammation. Maybe occasional endothelial cells are kind of lifted up. And then let's look at the bile duct. See how bad the bile duct is? This bile duct should have had at least another 5 or 6 nuclei, and we only see like 1, 2, 3, 4 nuclei. The rest is all gone. They're dead. So there's definitely bile duct injury, subendothelial inflammation, and then portal inflammation. One thing that I should mention here is, I know I was mentioning earlier that when you look at it on low power, it looks like chronic hepatitis pattern of injury with more findings in the portal areas. But in severe cases of acute cellular rejection, you can also see inflammatory cells, especially lymphocytes, in or around the central veins too. And that particular entity is called central perivenulitis. So this is a central vein, And if we start seeing too many inflammatory cells, so it's very similar to what's happening in the portal vein, the inflammatory cells invading the portal vein endothelium. Something like that happens around the central vein too, and that entity is termed central perivenulitis, and that's also a feature you can see with acute cellular rejection, but you see that more commonly with severe acute cellular rejection than mild and moderate. So we went through these two, and then
They don't have antibody mediated. Do we have antibody mediated over here?
let's see. Let's look for rejection. I think we didn't see any here. Huh, that's interesting.
We might not have the transplant livers.
No. Oh, moderate acute cellular rejection. All. That's funny that it's not coming under liver, but so yes. So compared to these previous Michigan ones, see how now this was called mild, right? So see the portal inflammation. There's not much happening in the portal areas, right? Like on low power, there's very little inflammation. And then compare it to what we are seeing here. There's a lot more inflammatory cells in the portal areas. And then if we go closer, there's frank bile duct injury. These are lymphocytes in the bile duct epithelium. And then look at the amount of inflammatory cells that are underlying this portal vein endothelium. That's a lot compared to this previous case. There are not that many inflammatory cells right here. And then, so there's bile duct injury and then subendothelial inflammation, and then just the sheer amount of inflammatory cells in the portal areas. So overall, this was called moderate. Let's see if there's anything happening in the central veins. Like here. I think this is a central vein. It's hard to tell because there's already a portal area here. So I'm guessing this is a central vein. If not, let's see if we can find similar. This is another bile duct that's severely injured. It's once bile duct injury is severe, it almost becomes hard to tell whether it's a portal area or not. This is another portal area. Look at the extent of bile duct injury here. I'm not seeing good. I guess this is a central vein. Yeah, there's a little bit of inflammatory infiltrate around the. See this? Little bit of inflammatory infiltrate around the central veins. So this is early central perivenulitis, which can happen with acute cellular rejection when it's like moderate to severe too. Let's see if they have any other type of antibody mediated or chronic rejection. No, this is looks like kidney.
Try antibody.
Chronic antibody.
No.
Let's see. Oh. Kidney or liver? Oh God, kidney. Kidney.
Do you not get antibody mediated that often in liver?
Very rarely. So in the last 5 years, we probably had about 3 cases.
That's fine. Okay, then we can just leave it. Yeah. Maybe you can show us some cancer cases, like hepatocellular and the other cancers. I mean, I don't know if we have enough time though.
Sure. Let me quickly check. There was a ductopenic rejection, chronic rejection. So let's look at that before we go on to tumors. So this is an explant. So if the patients don't take their immunosuppressive medication, despite getting several episodes of acute cellular rejection, they still fail to follow the protocol for immunosuppression, then eventually over a period of time, after repeated episodes of acute cellular rejection, they go into chronic rejection. So we do get cases where patients have that. And so the way we can tell is in chronic rejection, there is almost no inflammatory infiltrate. And this is not the best case, unfortunately, because we need to look at the smaller bile ducts. These are all larger bile ducts. And then when we look at the portal area, the bile ducts are almost degenerative looking, they have very eosinophilic, or maybe here. This is still somewhat well preserved, but some very eosinophilic cytoplasm. There's hardly any inflammatory infiltrate. And then eventually the bile ducts are lost. So that's why it's called ductopenic rejection. And so once over 50%, so we have to, before we say there is ductopenia in that case, we have to make sure that at least 50% of the portal tracts don't have bile ducts. And once that happens, eventually, they have to get a new transplant. Because after, when they develop chronic rejection, no amount of treatment will revive the liver back, even if they start taking their immunosuppression well, because they've lost a lot of bile ducts already. But this is not, unfortunately, a great case to show, because all we are seeing is the larger bile ducts, but the smaller bile ducts not very well preserved. And there's a lot of loss of hepatic parenchyma here. So let's see, there's one more ductopenic rejection. Oh, this is also an explant. Oh yeah, so look at this. Once again, this is a portal area. As you can see, there's a hepatic vein, portal vein, hepatic artery. And then where there should have been bile duct, you don't see a bile duct. Instead, you just see some histiocytes. And then this is an artery, hepatic artery, and look at the histiocytes here. This is known as foamy cell arteriopathy. And this is another form of chronic rejection. Once it reaches this stage, again, it's hard to reverse it. It's important to mention to the clinicians that you're seeing histiocytes within the arteries, which is a big indicator that the liver is going into chronic rejection. But look at the amount of inflammatory cells compared to that moderate rejection case that we had. Like, see how much inflammatory infiltrate there is here. There's very little inflammatory cells here comparatively, because this is a much bigger portal area. So, so those two changes, loss of bile ducts and then foamy arteriopathy, are features of chronic rejection in the liver. Okay, and then let's see, said tumors. So let's get rid of this and go to just liver and biliary. Should we use a particular term? Maybe adenoma. Start with adenoma, right? So a lot of times, at least in the modern era, detecting these adenomas happens incidentally. Patient is come in for some other disease process. They undergo either a abdominal CT or PET, and then they see some kind of lesion in the liver, and then they go after it. That's why these days we are seeing these lesions much smaller than what you would have seen 10 or 15 years ago. And so when they go after these lesions and biopsy them, it's quite a few times challenging to like even see where is the lesion in this biopsy, because invariably we'll get the normal liver parenchyma in the background a little bit, and then you're actually hunting for the lesion itself. So one way you can feel comfortable that what you have is lesional tissue is absence of portal areas. So whenever you get a liver biopsy that says it's been biopsied for lesion, you start going through the biopsy from one end to the other. And as you can see here, there's a portal area. And so that tells you the presence of portal area, that this is normal background liver parenchyma. And then you keep going along the core, and then no matter how far I go, I'm not seeing another portal area until I come here. And here I'm not seeing a true bile duct. Maybe here, it's hard to say. And it's the same here too. And then we have bile ducts here. So it makes it challenging. And I think here we have what is known as naked arteries, maybe, which is somewhat indicative of maybe this is an adenomatous lesion, because there's no portal area, a good portal area in this part of the liver. And we are seeing these naked arteries. And so that should make you start thinking about, oh, is this a hepatocellular lesion? Most likely, adenomatous, because it doesn't look too ugly to think of HCC. So the two common lesions that one should rule out, the most easiest to rule out is FNH, or focal nodular hyperplasia. So you can do a glutamine synthetase stain. That's very helpful. And then you can do, depending on the institution, they have different adenoma markers. The most common ones most institutions have are beta-catenin, fatty acid binding protein, and then serum amyloid A protein. Let's see what they call this. So they say it's an inflammatory type adenoma. I was hoping that they would give, do these have immunostains? Do you know a function? I don't think.
I thought they had some trichrome, but I don't think they have immunostains. I'm not sure.
It's like this, and this look very similar. So let's see what this is.
CV34.
I don't think that helpful.
If you're talking, we can't hear you.
No, I'm not talking. I'm just saying I don't
Yeah.
think or is that helpful. Okay, there is a trichrome here. And not very helpful, because I think they did the trichrome to like see where the portal areas are. There's one here, there's one here, and then this stretch from this portal area all the way down here, we don't really see a true portal area. Let's see if we have other stains. Maybe this one looks very similar. Yeah, serum amylase A. This is what I'm talking about. And so this is background liver. And C, no, sorry, this is background liver. And it's negative here. And then so apparently, if we go, I think the H&E is not the best, unfortunately. Okay, here. See how the hepatocytes are kind of compressed. They look, compared to these hepatocytes from the background liver, there is a compression of the cords, but their sinusoids are extremely dilated. So, and that's something that you can appreciate with telangiectatic or inflammatory type adenoma. So I was thinking that the lesion is most likely here, but based on what they're saying, it's here more likely. Because I was going off of the portal areas in this case. That's why, you know, looking at cases online makes it quite challenging. But this segment has telangiectatic dilatation of the sinusoids. And so what they've done in this case, not this one, yes. What they've done in this case is done a serum amyloid A stain, and it's picked up by the hepatocytes in this region, and inflammatory adenomas of the liver stained with SAA or serum amyloid A. And so this is the inflammatory type adenoma. So there are conventionally 4 types of adenomas: the beta-catenin mutated ones, the inflammatory type, which is also known as the telangiectatic, and then the fatty acid binding protein loss, which is the steatotic adenomas. And then
There is a HNF alpha mutated one.
yes. So this is the inflammatory type. So most institutions don't have this stain. So when you don't have it, you can still, based on the H&E morphology. The one thing that you have to keep in mind when you look at or investigate a hepatic adenoma is to make sure that it's not beta-catenin mutated, because those are the ones that have high propensity to develop into HCC. So the least you should do is do a beta-catenin stain, and if it picks up beta-catenin, especially if there is nuclear beta-catenin staining, then that's abnormal, and you should report that and say that, you know, you can say that if it's not classic, you know, lesional tissue, you can say that there is a focus within the liver biopsy that's picking up nuclear beta-catenin, and this raises the possibility of a beta-catenin mutated hepatocellular adenoma. You know, if clinical concern exists, then this lesion should be followed up in long term. And sometimes what they do is they wait for a couple of months and then, you know, re-image them to see if the size of the adenoma has increased. If it keeps increasing, then they decide that, especially if they know it's beta-catenin mutated, they go and try to resect the adenoma. If it's one of these, like the telangiectatic or the HNF1 alpha mutated, they try not to take it out. They just follow them up, unless these are large and causing them symptoms. Let's see if there are any other. Looks like we only have one type of adenoma. Only one page. They don't give. A lot of times it can be challenging to even appreciate these adenomas on sections. We have to look at the background liver and say that, okay, this looks somewhat like background liver because you have bile ducts, some inflammatory infiltrate, central veins here. And then, you know, on low power, this area kind of stands out, separate from the background liver. And then if you go in and kind of move around, you start seeing that there's really no bile ducts. This looks like a portal area, but all you have is an artery and a vein, but there's no bile duct. So this is most likely a lesional tissue. And then a couple of things you can do is do a reticulin and see if the trabeculae are expanded. And then you do a beta-catenin. If so, for general practice, if beta-catenin is not expressed in the nuclei, it makes your life a lot easier because it's not an adenoma that's going to progress easily to HCC. So you can always say hepatocellular lesion, C common, and then say that beta-catenin is not overexpressed or is not nuclear in this case. And then if you have additional stains, you can still run it at your institution, namely serum amyloid A or fatty acid binding protein. And then say that this is most likely not beta-catenin mutated. Other than that, let's see if Michigan has any. Liver cell adenoma. So same story here. We have the background liver, and we can tell that by looking at the portal areas. And then you have this very steatotic looking area. And so this is most likely, are there any bile ducts here? Looks like there are no bile ducts here, even though they look like portal areas. You only have vein and artery, but no bile duct. So, so this is the lesional area, and this most likely, if you do a fatty acid binding protein, then that will be lost in this area. And so you can say that this is an adenoma with loss of fatty acid binding protein. And so it's most likely not going to be, not likely to behave that bad. Another hepatic adenoma. Again here, so what do you see on low par? Once again, you can see that the sinusoids are dilated here. So this is very similar to that first case, the telangiectatic or inflammatory type hepatic adenoma. You can see the inflammatory cells here. So if you do the serum amyloid A, it'll stain this particular area. So we saw at least 3 different types of adenoma. The only thing we haven't come across, I guess, is the beta-catenin mutated. Let's see. So once again, we have the background liver here because we have the bile ducts in the portal area. And then we have the lesion here. See how steatotic this is? And so you can do the fatty acid binding protein. And if that's lost here, you can call it an adenoma with loss of fatty acid binding protein. I think those are the ones. The rest are all. Okay, and then we can go to HCC. Any questions so far?
I don't know how binded you are on time, but I just wanted to remind you it's 5:08. We will be listening to you whatever time you will tell, but just wanted to remind you.
Thank you. Let's see. Biopsy ones are always challenging. This one is also most likely a telangiectatic with some sinusoidal dilatation here. A lot of them are not straightforward, unfortunately. Needs workup before we can classify them. Let's see, hepatocellular carcinoma.
How come they are opening today and they were not opening yesterday?
Maybe it's their server. I don't know.
Format. Yeah, yeah.
So I'm hoping it will be more straightforward than biopsy. And I'm cirrhotic. So you can see this is cirrhotic liver. Background liver is cirrhotic. Okay, here. To see how subtle it is, when you look at these scores, you kind of lost, where is the lesional tissue? And all these cores have background liver, which looks cirrhotic. And then this one fragment, if you come closer, what do you see here? What kind of structure are they forming? Pseudoacini, right? That's a feature of HCC. And then you can see that between here and here, there's no bile ducts. And then when we are making a diagnosis of HCC, the most helpful stain is reticulin. And if you were to do it, even though the background liver is cirrhotic, because the regenerative nodules can show expansion of the cords, here in HCC area, the reticulin fibers will be lost or massively expanded. So that's one thing that'll help. And then the morphology in this case. So if you compare, keep these cells in mind. Look at how large the nuclei are and how the arrangement of the hepatocytes, they're somewhat forming these pseudoacini. And then remember that and go back to the background regenerative nodules. See how bland these hepatocytes are compared to that. So that's what kind of gives away that this is HCC. And then if you want to confirm, morphology is more than enough in this case, but loss of reticulin is a good confirmatory stain. If you're still not convinced, you could do arginase or Hepar, but it's already in the liver because you have the background liver. So to me, other than reticulin, you don't need any other stain here to make the diagnosis. Give me 2 more minutes. So there's HCC with clear cell features. So HCC can have several morphologic variants. So clear cell feature and steatohepatitic variant of HCC are the more common ones. And see how this almost looks like renal cell carcinoma in some ways. So the way you can tell is that you have the background liver here, which has portal areas with bile ducts, right? These are all bile ducts. And then you zoom out, so you know that's the background area, and then this is the lesional tissue. And here, the hepatocytes are forming these ugly nuclei, multinucleated, and occasionally you can see pseudo-rosette formation. And then when you come on over here, look at these trabeculae. Each of these trabeculae, instead of having 2 cell thickness, there are how many? 1, 2, 3, 4, 5 cell thickness. These trabeculae are extremely thickened. And then they also have the clear cell change to it. So this is HCC with clear cell variant. You can say this is moderately differentiated. Well differentiated HCC is usually hard to distinguish from the background liver because it looks very similar. So that's why, bile formation, loss of reticulin will help you in picking up well differentiated HCC. But moderate to poorly differentiated HCCs are easy to pick up. And then, oh yeah, the fibrolamellar variant. So fibrolamellar HCC is usually seen in young patients, patients in their 20s to 30s. Sometimes I think even in teenagers, like late teenagers. The key to note is background liver is not cirrhotic in these cases. And the morphology is somewhat characteristic. You can see, let's see if there's one more, because this is very eosinophilic. This is much lightly stained. So it has this characteristic, somewhat like these fibrous bands that go through the tumor, between the tumor cells. And that's something that should, like these characteristic collagenous bands that go between tumor cells. And that should usually help you. So the young age of the patient, non-cirrhotic background, and then these fibrous bands. And more recently, they've shown that these HCCs have characteristic mutations in them with the DNA JB1 as the partner. I think it's a translocation. So that if you suspect it, you can send it for testing. I think Michigan Labs performs it and UPMC also performs it, I think. But morphology is enough. You don't have to send it for molecular testing. I think those are the different kinds of HCC.
Those HCC that has 2 images might have a reticulum in there.
No. Biopsy.
No, they are not.
So here, it's a cirrhotic liver. And we have this very ugly looking. So this type of HCC, can you see how the trabeculae are quite large? So if consistently more than 50% of the trabeculae are larger than 10 cell thick, like if you count from one end of this trabeculae to this end, consistently 50% over 50% of the trabeculae have more than 10 cells, then it's known as macrotrabecular HCC. And the significance of that particular morphologic variant is that they're more aggressive. They almost behave like cholangiocarcinomas. So their prognosis is very bad. You can have extensive lymphovascular invasion from those HCCs. And those can also happen in non-cirrhotic livers as well. I think we've covered a lot of HCC. This is not the best. They call this well-differentiated HCC. See how it's hard to tell whether this is background liver or HCC. I think if you were to do a reticulin stain here, it'll be lost, and I think that's what Hint said. HCC. I guess we can stop here. It's already 5:18. So, any questions?
Sure. That well-differentiated HCC has 3 images. I wonder if there is a reticulum in there.
Let's see if there's a reticulum.
They don't have a reticulum.
Oh, this is a reticulum. Let's see. What is the lesion though? Wish they circled the lesion. Oh, here, I think that's the lesion. No, it's still preserved. Why don't we just Google it? HCC. That way we can. So this is what we're talking about. So if we were to look at this image, here. So this is background liver, this is HCC. So look at the background liver. The reticulin fibers are evenly enveloping or covering each of the hepatocytes, right? But here, you're only seeing the nuclei of the hepatocytes, but no reticulin fibers surrounding individual hepatocytes. It's lost, so that you have this one fibrous band, but from here to here, there's no reticulin fibers. But imagine the same in the background liver. From here to here, you have how many reticulin fibers here surrounding individual hepatocytes? So that's loss of reticulin. Let's see if there are other images. The other way reticulin will be lost is, like this. It's still retained in some areas, but see from here to here, it's lost. It's the same here. So this is background liver where it's retained. Here it's expanded. But I think what we saw here, this was the best, where you have background liver where it's retained, and then here it's completely lost. So that's what I'm talking about when I say loss of reticulin. A very helpful feature. I guess.
All right. Thank you very much, Dr. Akki. I think that was a great session.
You're welcome.
Hello?
Can you hear me?
I am particularly not able to hear you. I don't know if other people, because my audio is not that great today.
Okay. Well, I guess we can.
Yes.
Yeah. Thank you.
Thank you very much, Dr. Akki. Thank you.
Bye.
Thank you.